Can you hear me, Freddie?
Hey, how are you?
Doing well. Now, I want you to know that everybody here in the room is giving you a hand up for being down there for that big Steeler win yesterday and making it here today, and everybody's appreciative.
And I haven't slept all night. I went to a party, 3 o'clock, dancing with Heinz Ward and everybody. And
well, as soon as you get done with your lab, we'll keep your blood alcohol level up.
Yeah.
Okay?
Yeah, we'll have an hour, so I'm going to get going. But essentially, the exercise I'm going to show you right now is to try to, reproduce 80 to 90% of the anatomical, material of the ACL, and hopefully will keep the knee healthy in the long term. Now, I have Don Shelburne, Elizabeth Aaron, and Brian Coe and other people here too. And I have, Tony, my old fellow. Now he's in Sun Valley helping you. So I'm going to start with the portal, very important. I use 3 portals. This is outside of the knee. Can you show the outside? This is the lateral portal, and the main thing is to look inside on the tibial insertion site, okay? And and this portal, give me a probe in the middle. This is through the patella tendon, in this case, but not necessary. This is looking up in the femoral insertion site. So this portal is important to look at insertion site on the femur. This third portal is to drilling. If you want a medial drilling, this is away from the condyle, about from the meniscus. You can drill on the PL bundle as well as the AM bundle. I also want the audience to mentally memorize how this looks like. This notch is a good size. This is about 14, 16 millimeters notch. The P-cell, this is so-called the Howe triangle, which is a normal structure. And the A-cell is this from the lateral portal. So if you extend the knee, there should be no impingement. In other words, if you do a A-cell anatomically within the range of this insertion site, you should not do a knot. You don't need a knotplasty, nor you need to do any more things to make the anatomical, insertion site right. Now, let me get a ruler right now. Now, I use a ruler. This is a ruler right here. It's a very simple, malleable thing, okay, very malleable. So I'm going to put a ruler in. I'm going to measure now the size of the insertion site of the tibial side, okay? And look at that. This is the PL bundle all the way here. See that? The PL bundle actually attached to the lateral meniscus right here, and attached right here. Dr. Shelburne told me that he doesn't believe it may be ACL material, but I'm not sure because I did a lot of study, histological too, to see there's 2 bundles there. But anyway, I start to measure from here all the way to the front. This is about 18 to almost 20. So this is a big enough size to do a double bundle. About 25% of this insertion site are 14 or less, about 25%. And in those cases, we prefer to do a single bundle in those cases. Now I'm going to move my portal to the medial side. Okay, on the medial side, I'm looking up. Give me a probe right now. I'm now looking up from the central portal, my probe in the accessory medial portal. You can look outside for 1 second. Outside? Okay, outside? Okay, good. So now this is, I call the axis of evil. This is where we should not put the ACL. But I'm going to tell you, this is where I put the ACL in the 90s and about 5, 6, 7 years ago. This is the most common with over-the-top guy right here, okay? And this is insertion site. You can see the PL bundle and the AM bundle. The PL bundle is loose at 90 degrees and extend the knee. Now, the extension is vertical, and this is your old clock position. Stop right there. Don't be too vertical. So essentially, this is your old clock position. Okay, 90 degree. Okay, so you cannot describe the knee as the old clock with this portal. Now, Tony, can you put the probe right here at the center of the ACL right here? Put it right here. Now, this is the center of the ACL. This is between an AM and PL. If I do a single bundle, I would probably put it right here. Now, I'm going to put my scope laterally now. And I want to ask the audience, what old clock is this? This is really low, okay? I don't know how to describe it because this is not really 9 o'clock. This is really super low. And if you want to put your hole, for example, in this position, which I used to do many, many years. In fact, I think when Brian Coe was my fellow, this is where I put it. Hold it, Tony, right there, okay? Hold it right there, okay? No, don't move it. Hold it right there, okay? I'm going to show laterally. Okay, he moved. Okay, Tony. All right. Okay, hold it right there. Don't move, okay? Okay, all right. So now, this is my 10 o'clock position. Okay, this is my 10 o'clock position. And I'm telling you, I don't think that we can use o'clock to describe this because it's a three-dimensional structure. Now, let me measure on the thermal side too. Now, thermal side, we find a few interesting factors. You have to bend it a little bit, okay? So, the thermal side usually is about 2 millimeters smaller than the tibial side. So, this is about a 14, 16 thermal side, okay? All right, so, and if you look at it vertically, the PL is about 6'7", and the AM is bigger. So if you do a perfectly tan BTB, the bone block above, you probably can put most of the graft within the hole. But if you malplace your 10 millimeters hole, you'll be out of the range of the ACL, okay? Right here. So these measurements are very useful for me, and I think this is a very easy way. Now, also, I measure the notch. Hold it 1 second, okay? I can bend this ruler any way I want. And I'm going to put this inside, and I measure the notch. And this notch is a good, 14, 15, 16 millimeters. So this is a, ACL. You can definitely do double bundle. You can easily do many, different kind of surgery. But anything less than 12, Dr. Shelport and I both agree, it's very hard to do the case, and I will not do a double bundle. Anything less than 12, okay? So this is, and I think notchplasty may not be a good way because notchplasty grow back. And basically, the size of the notch is related to the size of the femoral condyle and all those things. So there are many unknown. We do not know how it works. Now, one more thing. I want to look at this ACL, memorize it. Basically, ACL look like this. If you put it perfectly, like this, when you run or play sport, there are more forces down the ACL than you put a vertical graft. If you put a graft from the PL to a high AM, a vertical graft, when you run, you don't have this shearing force. So instead, the more force are through the femoral condyle. We just complete a biomechanical study in Pittsburgh to show a vertical graft actually see less forces compared to a normal placed ACL. So interestingly, a normal ACL actually can re-rupture easier than a vertical placed graft. And Don Shelburne article just came out to show you that there's a re-rupture rate about 6%. You always re-rupture. If people tell you there's no re-rupture, it cannot be accurate, okay? These people are very active. Okay, now I'm gonna do one thing. I'm gonna take off the AM bundle, leave the PL bundle intact. Can you up the thermal? Now the thermal, I usually use the lowest size, okay? So about 100. So the AM, I'm going to do the AM. Now normally, you don't see this kind of anatomy in the chronic cases. But in a case within 3 months of injury, you will see the insertion site. If you see the insertion site, you have to be very carefully, map it out so you know where it is. So this is AM bundle insertion site. Okay, AM bundle. I'm going to take a little bit of AM off from here too, okay? So leave the PL intact. I believe AM, I'm going to leave the thermal insertion site intact. Okay, so AM is going away right now. Okay, I'm taking the AM away. I'm going to leave the PL intact, okay? What time I have right now?
You're good, Freddie.
10 minutes into it, okay, good. My technique is a little bit different because I really show the anatomy a bit more, okay? So it's going to be a little bit more time consuming than is it working? Okay, good. So I combination of shaver and thermal, okay? Oh, all right, give me a measurement guide. So I'm gonna measure this. This AM is about good 10. So in real life, I can do an 8 graft easily, and the measurement of this is almost 10, okay? So this is AM now. Let me give a probe. I want to show you what is the PL bundle like. This is the PL bundle. I think both Dr. Clancy and Dr. Shelburne may not believe the PL bundle. Some people don't, but this is the PL bundle. I don't know how you can deny this is a bundle right there. This is quite sizable. This is almost like a Chinese sausage right there, very edible. And in 90 degree, it's loose. Why is this loose? Because now it can rotate it, okay? You can rotate, but the extension, if the extension slowly extended, it becomes tight, like the AM bundle. No, not too much, okay? If too much, a little bit less, okay? Now it becomes tight, like the AM. Now let's look at it from the central portal. Okay, again, the AM is gone a little bit. This is PL, and I think there's argument whether this is really a ligament, because Don is right here, and he doesn't believe, but with this extensive histological, study, and even in newborn and fetus, to show this is really a bundle, here. Now, of course, with the activities we do, this may become bigger and smaller. But in animal kingdom, this is very big, because they need more rotation. AM is right there, okay? So this is the PL bundle, right there. And I think single bundle, you can do it right here, double, right, PL and AM. Okay, now I'm going to go back. I'm going to start taking the PL bundle off on the tibial side. Okay, so the PL bundle is right next to the meniscus, so it's very dangerous. Sometimes you can harm the root of the meniscus. Okay, so I use a very low thermal. In acute cases, less than 3 months, you can see those remnants very easily. Okay? The femoral side, because most ACLs are torn on the femur, you may not see the femoral side as good. But the tibial side, you can usually see it after 1 year post-injury. Shaver. Okay, I'm going to use the combination of shaver to look at it. Okay, so this is PL bundle attachment right here. I'm going to get a little bit of the remnant of the femoral side too, okay? So this is PL bundle, still a little bit attached. Thermal again. So next I need measurement. So again, this is PL bundle attachment right here. Give me a probe next. So the PL bundle I showed you earlier is right to the meniscus. This is a root. I have seen people do double bundle, they didn't know that so close to the root. So they damage the root, and right next to the P cell too. Right next to the P cell, okay? So PL is going to be right here. AM, let me mark it with a thermal. So the center of PL is going to be around right here, okay? And the center of AM, you can see around right here. And if you want to do a single bundle, you probably see somewhere around here. Now, by the way, the shape of this particular insertion site is quite straight, but sometimes it's a bit, cayenne too. Give me a ruler. So like I say, the PL in this case is about 8 and across. So it's about 8 by 8, okay? So 10 by 10, 8 by 8. So in real life, I probably would do a 6 and 8. I can use an autograft hamstring quadricep tendon with a bone block above, or a allograft. A quadricep graft probably give me the biggest double bundle size, more than hamstrings, okay? But today I'm going to do 5 and 6, just because they have graft prepared already. Now let's go to the femoral side. Shaver. Now femoral side. What time I have right now?
You're at quarter to halfway.
Oh, halfway. I'm going to see anatomy. See that this is AM and PL bundle. Now, I want to make sure that you can see it's a bundle right here. Okay, look at where the PL go. It's a true bundle. This is insertion site of the ACL. Okay? So the ACL should not go above here. Okay, give me a ruler. Again, you can see the insertion site of the ACL. All the way back there is about 16, like I say. And then the PL, about 6 and 8, and the AM, maybe about 9 or 10, okay? Right there. So you have an idea where it is. Let me give a thermal back. I'm going to now mark the PL area again. Now, I want you to see from the outside. Right now, okay, from outside, where it is, I'm going to change my scope to the lateral portal. Okay, I changed the lateral portal. Now, what do you see? You don't see that. You will not appreciate the insertion site of the femur. You will see something, some remnant. You see it? I tell you, if I teach you nothing today, use the medial portal. You'll see such more. So this is PL area. So this is insertion site of the PL. And I don't know how we can deny that. It's right there. Okay? You can see up and down. And this is AM. But you can do single, double bundle. I don't care what we do. But this is where you should go within the insertion site of the bundle. Okay? So this is the upper part. And if you are lucky, now actually you can see the ridge that Clancy described. See the resonant ridge right here? Right there. You have to use a low thermal to see it. And you can see the AM and PL slope. And sometimes you can see a ridge between the two too, if you have very low thermal. But this is a little bit high. This is resonant ridge right here. You can see. Can you see, Tony? Can you guys see the resonant ridge right here?
Sure,
Right here.
We see it well.
Right here, right? You can see it. Okay, so PL is here, AM is there. Okay, AM is right here. Let me shave a little bit. When I use the shaver, I'm very careful not to overshave anything. Okay, don't touch a bone. Now, in chronic cases, you can use the femur as a guideline. Like is this in revision case or a 5-year case? The femur will be a very good guideline to the size of the ACL because you may not see anything on the tibia too. Okay, so this is the whole insertion site. Okay, of the ACL. Now, give me a probe again. So your choice is this. Your choice is you can do a single bundle right here in the middle. If you want more AM, then you can move here. If you want PL here, but most people do it right here. I do it right here, or more people like Clancy like to do it right here, okay? Or Dr. Shelburne like to do it right here, which is fine, okay? I do it here, and Charlie Brown too. More in this area, okay? More in this area, okay? But I like to do a little bit half and half, maybe 40, 60, okay? Now let's seminar. I'm gonna hyperspeed now because this is I'm gonna mark the PL. Okay, good. Just mark it. Good. Bang it in. Yeah, put a hand right there. Good. So this is the PL area. You can see. If you don't like it, you can take an X-ray and see if. Oh, my God, the whole thing fall out. Okay. Tony is too powerful. The whole, Okay. Okay, good. You can. Okay. So PL hole right there, and AM hole is about, over the top position right here. This is the resonant ridge right here. It's going to be about right here, okay? So I'm trying to be more accurate about it. All right? All right, so AM here, PL here, and middle right there, okay? But anything outside is outside the anatomical range. Give me a pin. Now, I drew from medial portal, and usually I bend the knee to 120 degrees, so it's a longer tunnel, but I'm not in this case. I can see, okay? And Clancy is a guy too, very good guy. Bang that in. We're gonna drill 5. Demonstration, I don't bend the knee because you cannot see too well. We're gonna drill 5. Because if you bend the knee, you'll get a longer tunnel. You'll get about 30, to 40 tunnel. If you do it like this, it's a little bit dangerous. It's near the nerve, okay? So we're just gonna go through, Tony, just go through. Demonstration, because I only have a few more minutes left. In reverse. Okay. Good, thank you. Okay, good. So this is a 5-millimeter hole. Like I say, if you do it with a knee band, you can do a longer tunnel and more graft. But this is the PL bundle. 10 minutes? Okay. All right, let's do the tibial side. Now I'm going to leave the femoral side and go to the tibial side, okay? So again, this is a to-the-point guide. So I'm going to drill the PL bundle. This is meniscus. I marked it previously right here. This is PL, and this is AM. We marked previously, okay? So PL right there, okay? Good. And I do it at 45 degrees. 45 degrees. You can extend the knee just a little bit to do it. This is the cadaver. Okay, good, go. This is to the point, guys, so everything is very simple. Okay, good, back, okay, good. So this is a little bit close to the meniscus. In real life, I probably will move it up a millimeters, okay? So PL is done. All this technique is simple technique, nothing fancy. You don't need anything drill guide, okay? So this is, if you do a single bundle, it'll be right here. And if you're gonna do a double bundle, it's gonna be right in the middle of the AM. Okay, good. So Tony, you're gonna drill the AM?
Give the drill, give the drill.
Now at that point, I would usually take X-ray, see where I am. Are you there, Tony? Are you 55? Good, good. Okay, up a little bit more. Up a little bit more. Good. Yeah, perfect. Okay. Get out. Now give me a ruler. Good, good. Now I'm going to measure the distance between the two. Okay, so this is a good 10 millimeters. So if you're going to do a 5-6 hole, it should be fine. Okay, there'll be plenty of room. Now also, look very carefully on the lateral side. If you look at that, you think the AM bundle is a little bit too lateral. But if you're going to look at from the medial portal, you know it's fine. Plenty of room, okay? Probe. Remember, the PL will come here to this hole. The AM will come here, not here, okay? The AM is dive right here, right there, okay? This is where it belongs. Let's drill it, okay? Let's drill 5 and 6 or 6 and 6, whatever it is, okay? So how much time left now?
8 minutes.
8 minutes. Oh my God. Okay, let's go. So usually I put a curate through it. Okay, we have to know where it is. Okay, go. We have to know where it is. Give me a pin. We're doing high per spot. I'll make more money. I'm gonna do more double bundle now. I can. Usually it takes me about 1 hour to do it, 1.5 hours sometimes. Okay, because yeah, good. Okay, good. Give me a guide pin now. Give me a free guide pin.
They have it,
Free guide pin.
yeah, he has it.
Free. Come on. Why you have to? Just a free guide pin. Now, for the female side, I'm now through the medial portal, so you can definitely get to the side, no problem, right here. Okay, now, no, yeah, another thing. Okay, so this medial portal you can do easily. Now, I want you to look, make sure that you know that it's away from the condyle too. So when you draw a if you drill medial portal, you don't do that. You can also use a re-entry guide. So you can always, probably 98% you can get it. Some small narrow notch you cannot get it easily, okay? And also you bend the knee, Tony, bend the knee. If you bend it to 120 degrees, you can bring this out easily. Okay, now maybe put it through the AM bundle. Where's the AM bundle? Okay, now this pin is through the AM bundle. Now if you put the AM bundle, hold it, Tony, hold it. Now, if you put it in a bundle, you can see this pin will be almost, if you drill like this, you're 100% out of the anatomical range. Okay? Now, let's look at it from the lateral portal. Well, this is vertical, definitely vertical, okay? No question about it. Even from the viewpoint, this is probably a good 11 o'clock, but if you extend it, it's really bad. So, no anatomical. Now, let's go for the PL. Where's the PL hole? Let's find it quickly. Okay, where's the hole? Okay, now let's go from PL. Now PL actually, that's why we've been doing PL to AM, okay? From the PL bundle, actually, you can reach to this hole sometimes, okay? So I think we can have choices doing through the PL to AM or medially, okay? Either one. So why don't we try PL? Now this one, I would say, this is the upper portion of the ACL, so this is right here, okay? So why don't you pound it in, Tony? Pound it in, okay? We're gonna do PL to AM. I do it about 50% of the case. Okay, now let's drill this. 50% I can do PL to AM, but the graph will be bigger, so this is special drill. Go. 6, right? Go. Good. So go all the way through. All the way through. Okay, I'm going to pass the graph right now. All the way through. Okay, good. Good. So, yeah, and like I say, in the medial portal, medial side, you can usually do it. You have a dilator. Put dilator. Put some dilator into the hole.
I have 6.
Oh.
6 for the PL.
And 6 in the AM, and then the PL, we just put a shaver in there, okay? You find it? No, cannot. Okay. Yeah, so the PL, you just put a shaver in there, okay? There's the hole. Okay, good, hold it. Hold the shaver. Now, you can see all of this, okay? You can see all of this. Not that high, come on, Tony. You can see anything. You get it high enough so you can see. So I always take a picture with all this 4 hole, so when you do a revision, you know where you put your hole, okay? PL, AM on the femur, PL, no, come on, Tony. Okay, all right, good. Let's look at it from the viewpoint from the lateral side. Now, on this point, you can see, beautiful, on the tibial side. On the femur, you probably can see the AM pretty well, but it's hard time to see the PL side, okay? So that's why we don't see the PL, because we don't use the medial portal, okay? Now, let's pass the graph in. Let's pass the graph in, okay? Okay, good. Take it out. Now, we're gonna take the graph in, okay? Okay, grab it. So this is, yeah, okay, good. Grab both then, pull it out. Come on, pull it out. No, what did you pull it out? Okay, so this is PL now. I need another pin. What are you doing? Yeah. Okay, so now, since I put the PL to the AM, I'm gonna put this PL to AM, and I'm gonna grab it through the AM. Okay? Tony, grab it through the AM. Give me a probe. Pull it back a little bit, pull it back. Pull it back, pull it back, pull it back. Yeah, good. Okay, good. So now, you can see, hold it. Now, you can see AM and PL cross, because in 90 degrees, the AM is the AP translator, whereby the PL is the rotator. As you extend the knee, hold it. If you extend the knee, you can see, extend the knee. Now, what was the pin in there? Why is it the pin in there? Oh, okay, pull it up, yeah. Okay, good. Now, you can see the AM and PL become parallel because in 0 degree, the AM and PL are both AP translators, so they cross, okay? Okay, let's pass the graph PL first. Okay, pass the PL. Good. So the PL go, just pass it. Just pull it through, that's the matter. So to demonstrate now, that's fine, okay? There's PL graph right here. AM, hold both sides, no. Mike, you can hold, yeah. So I want to thank Mike from Smith & Nephew and Maloney, too, to help me. Now, AM is 5 and 6. I can probably put a bigger graph in there. Okay, good. Pull it up. Come on, pull it up more. Put this up a little bit more. Yeah, come, pull it. It doesn't matter. It doesn't matter. Just pull it up a little bit. Yeah, that's enough, okay? Good. So, hold it. Hold both. Now, give me a probe. Remember how it looked before? This is smaller graph than the ACL. I have more room here. Dr. Shelburne like it. They have more room in the PCL area, okay? This is, like I say, this is PL bundle. You don't even see it, the AM. So this kind of patient, actually, with better motion post-op. I have 5% of patients have more motion, inflection post-op than pre-op because I put in less graft. This is probably, I could put a little bit more. This is probably more like 60-70% of the ACL. PL bundle here, they need to heal. They need to heal. It take a while for them to heal. Take 6 to 9 months, okay? So, and this is the triangle that we reproduce. Extend the knee. Extend the knee. Okay? We can extend the knee from this side. Okay, extend the knee again. No, slowly. Okay, good. Okay, good. All the way. Again, you can see, no problem with any impingement. No nodoplasty. Huh? Okay, so I think that you can see the principle is to restore about 80 to 90% of the anatomy, and is to put in the right place. Like I say, I'll show you some 3D CAT scan tomorrow, and essentially most of my growths are in this area. And I also want to thank Carlos Guantray, teach me all about double bundle many years ago. He taught me everything about double bundle. And now he is doing hip arthroscopy instead, all right? So anyway, I want to thank the audience, and I want to thank Dr. Burke, and also I want to thank Dr. McCaff, being a pioneer in arthroscopy. Thank you very much.
Well done, Freddie.
Thank you. Okay, thank you, everybody.
Go get a little rest.
Thank
Okay. Brian?
Okay,
Now, you are maybe the only guy on the faculty who can talk just as fast, so we're
I
gonna...
know. Yeah, and I want to do a good job because I don't want this. It's reminiscent of my fellowship 11 years ago, and I don't want Freddie to say I suck or I too slow.
Yeah.
So I'm going to make sure we do it right.
We'd be watching you.
I watch you. You suck or you slow? Take care, Freddie. Okay, so
You already slow.
Okay, so.